Okay, everything is now set. So good morning,
Great.
everybody.
Good morning.
My name is Mark Miller. I'm the Zoom host. I'd like to let everybody know that next week we will have the Wisconsin Humane Society Social Justice is the topic, and Ann Reed will be the program manager. So we'll now just go directly into our presentation from our speakers.
Okay, thank you, Mark, for inviting myself and Dr. Lorraine Halinka-Malko from the school to present today. We were just joking that when Mark reached out about having this presentation back in June, I wasn't quite sure what I'd end up talking about come December, but we are very much still experiencing the COVID-19 pandemic. So I'm glad today to have the chance to relay some information about what the Zilber School of Public Health faculty and students have been engaged in around COVID-19. And then, we'll answer questions at the end of our presentation. So I'll start by introducing myself. I'm an associate professor of epidemiology in the Zilber School. I started there in August 2013. And before that, I was a research faculty member at the University of Michigan. My research is focused on social patterning of infectious disease, studying links between infectious and chronic disease, and trying to understand pathways by which social inequities in health occur over one's lifetime and then across generations. And so I have had some experience studying and participating in studies that are looking at influenza transmission and transmission of other respiratory viruses, and thinking about non-pharmaceutical interventions like voluntary isolation or mask use in relation to stopping transmission of those infections in university settings. That's sort of some of the projects I worked on at University of Michigan. And so I have some background in infectious disease epidemiology and also an interest in social justice and health equity issues as they relate to infectious disease. And I'll let Dr. Malko introduce herself.
Hi, everyone. Good morning. I'm Lorraine Halinka-Malko, and so I'm faculty in Zilber School. I'm also an associate professor of epidemiology and our undergraduate program director. And my area is also in social epidemiology, but a primary focus on health, social inequities in health, and really at the community level and doing like community-based and public health interventions. And I have over 30 years of experience doing both observational and community level intervention research that has focused on incarcerated populations, low income, both rural and urban, immigrant, African-American, Native American, and Hispanic populations. And I try to do work that has some direct policy or program implications at the local or national level. And I'll be talking today about what I've been doing around COVID.
So the topics that we are going to cover in this talk are just giving an overview of the Zilber School and what our mission is. A little bit of update on the latest sort of numbers of COVID-19 in Milwaukee based off of the City of Milwaukee COVID dashboard. And then we'll get into a fair amount of kind of faculty and student engagement around COVID-19 that's been ongoing since March. In a range of different projects and areas that we've been involved in, both myself and Dr. Malko, but other faculty as well and students. So in terms of the School of Public Health, it was established in 2009, and it is now the only Council on Education for Public Health accredited School of Public Health in the state of Wisconsin as of 2017. We have 22 full-time faculty currently. And our mission was established for the purpose of advancing population health, health equity, and social and environmental justice among diverse communities in Milwaukee, the state of Wisconsin, and beyond through education, research, community engagement. Sorry, the screen here is blocking my view a little bit, and advocate for health promoting policy strategies. And we have a Master's of Public Health program where we offer a degree in public health in a variety of disciplines, including biostatistics, community and behavioral health promotion, environmental health sciences, epidemiology, and public health policy and administration. We also have PhD programs in 4 of these areas. And then in 2019, last fall, we launched an undergraduate major in public health. And so now we have a Bachelor's of Science in Public Health, which Dr. Malco has been leading and spearheading that effort to develop that program. So before we get into sort of what our faculty and students have been doing around COVID-19 since March, I just wanted to, get everyone up to speed. This is a data dashboard that the Milwaukee Health Department produces. So it can be a resource for finding the latest information about how many cases we have had cumulatively, how many deaths from COVID-19 we've had. There's a map in the middle that shows by the zip code of Milwaukee, the city of Milwaukee, kind of where the greatest burden of cases has been. It shows a breakdown by race, ethnicity, by gender, by age. And so overall, and on the bottom too is the 7-day rolling average of COVID-19 cases. So we can see how things have trended since March, and that most recently, towards the end of October, mid-November, we saw a huge surge in COVID-19 here in Milwaukee. The majority of cases have been cumulatively among those that are younger, actually 15 to 24 and 25, 34 years of age. While I'll talk about some of the trends across race, ethnicity that have occurred over the span of the past 9 months. Cumulatively right now, a similar number of cases have occurred among Hispanic individuals, Black or African-American individuals, and non-Hispanic white individuals, but we'll talk about how the burden has been different according to the population distribution of individuals in those race ethnic groups. And then about 6.8% of all cases are known to have been hospitalized as of today. There's a fair amount of people whom we don't know the hospitalization status according to this chart, just to point that out. But these are just some of the latest numbers, and anyone can check this website to stay up to date on what is happening in terms of that in Milwaukee. So in terms of our Zilber School engagement around COVID-19, I think aligned with our mission, immediately when the pandemic began and we first had cases, in Wisconsin and in Milwaukee, our response has been to help try to identify and assist with local COVID-19 related public health needs. And so this has involved, where possible, helping to track trends in COVID-19 cases, hospitalizations, and deaths over time. To help identify testing allocation strategies and where community interventions should be targeted. A lot of our students have been involved in contact tracing and other health department support, either through employment or volunteer work or field work experience. And I put a link here because we are updating our website, the Zilber School website, frequently, and you can get an updated list of the broader array of ways that we have been engaging and are going to be engaging in the future. So we're just highlighting some of those areas today. Another big element that I've personally been involved in has been around science communication around COVID-19. So I'll talk more about that. And then we have also been active in thinking about prevention and advocacy around COVID-19 and advocacy for health equity around COVID-19 and interventions that can ameliorate social inequities in COVID-19. And then there's a fair number of faculty that have ongoing research who have either received grants or have published around COVID-19. And so we'll highlight those efforts as well. So in terms of this first area of identifying and assisting with local COVID-19 related public health needs, at the outset of the pandemic, there was a Unified Emergency Operations Center for Milwaukee County formed that basically pooled together all those that are going to be engaged in pandemic response. So local county, health departments, the county, law enforcement, and other parties that are sort of coming together to form a plan and a strategy around the pandemic response. In early April, I was asked to join this epidemiology intel team that had been formed. And the lead of this team is Darren Rausch. He's the health officer and director of the Greenfield Health Department. He's also a PhD student in our community and behavioral health promotion track and a lecturer for our Zilber School of Public Health program. So this group is a work group that includes faculty from Medical College of Wisconsin, as well as myself, another faculty member from the Zilber School, Dr. Mustafa Hussein, and also representatives from various local health departments, Milwaukee County area. And what we have done is to access data from the Wisconsin Electronic Disease Surveillance System and other sources to produce weekly reports that summarize the latest COVID-19 data from Milwaukee County. And so I have a link there where you can access these reports. They get released on a weekly basis, and you can look over time how things have changed from report to report. We have a lot of cumulative measures as well as measures that are reflective of what's happened in the past week. In addition to these weekly reports, we have put out some special reports. Most recently, in mid-November, we released a report on social determinants of COVID-19 in particular, with an emphasis on thinking about socioeconomic and race ethnic inequities in COVID-19. We have also started to release a weekly kids report. So looking at COVID-19, particularly in individuals that are 18 and younger. And then a while back when we had some outbreaks in group living quarters, such as incarcerated populations, and also outbreaks in employment settings like meatpacking locations, we had an outbreak report that we released. And so really these reports are in response to what the local health departments might need or how we can help augment their efforts at data collection. So Darren Rausch, sort of is our health department liaison. And if there's something that he has a need for, we as a group try to respond to that. And he keeps us sort of abreast of what the data needs are. This group has also done a lot of troubleshooting around data. So when there's inconsistencies between data sources, or there's sort of data bugs or missing data, we have worked through those issues to try to clarify those data related issues. And I want to point out that these efforts of this work group were supported by funding from the Advancing a Healthier Wisconsin Endowment of Medical College of Wisconsin. It was a 6-month grant that's unfortunately ending, but the PI of the grant was Dr. Kirsten Beyer, who's an associate professor at the Institute for Health and Society, and the co-investigator was Dr. Mallory O'Brien, assistant professor, Division of Epidemiology. So this in large part funded the effort, but many of us just volunteered from the Zilber School on this committee in order to help translate the data findings, troubleshoot issues, but those two led the data analysis on a weekly basis with their teams. And so I'll just give some examples from some of the reports that we've produced. So this is from our last weekly report that was publicly available. I think it's data through November 24th. So it's about 10 days old in terms of the data. But this is just showing the cumulative, daily number of cases, not cumulative, but each day over time since March. And so, you can see that we had some surges, shows the city of Milwaukee, Milwaukee County suburbs, some surges that occurred in May and in July, and now unfortunately a much larger surge. And we're sort of waiting to see, what will happen after Thanksgiving holiday and those cases begin to be detected. We also have tracked deaths over time. And so this is just an example showing the daily number of deaths since March. Orange is the city of Milwaukee and blue is the Milwaukee County suburbs. And you'll notice that we have seen a reversal here now where there's more deaths happening in the Milwaukee County suburbs than the city of Milwaukee. So again, this is Milwaukee County data, not just city data. But the link is here. And so these are reports that anyone can access and see what we have produced in terms of tracking these cases and deaths over time. This is an example from the social determinants of health report specifically. So this is showing the 14-day incidence rate by race ethnicity over time. And the red line here is the African American or Black population. This green line here is Hispanic individuals. And so, you know, we can look at this chart in conjunction with this table showing the absolute number of cases that have occurred in each of these race ethnic groups, and then the rate per 1,000 residents. Certainly at the beginning of the pandemic, this rate among Black and African American individuals was strikingly higher than any other race ethnic group and very concerning. And then, you know, as we moved on in the pandemic, we saw spikes, increases in the movement of the COVID-19 pandemic to the south part of Milwaukee. And then now we've sort of, you know, seen this surge in cases that is occurring in the Milwaukee suburbs. And so overall, the incidence rate, taking into account population size, is fairly similar for Black and African American and white individuals, but it is almost double for Hispanic individuals in Milwaukee County. And then we're starting to see an increase in the other race ethnic groups, you know, that are now starting to maybe experience their own surges. And so this is something that we have been tracking all along and, you know, helping report to local health departments to like help them keep, you know, track of and target interventions to specific neighborhoods and populations in order to intervene and try to head off you know, the race and ethnic inequalities in COVID-19 that were being observed immediately starting back in March. This is showing the hospitalization counts by race ethnicity. So sort of, you know, a similar pattern where at the outset of the pandemic, hospitalization rates were highest among Black or African American individuals. Now we have seen a surge among white individuals, but overall the hospitalization rate among Black or African American individuals is nearly twice that of white, non-Hispanic white individuals and Hispanic individuals. And so, you know, we have in these reports, you know, made comment on, you know, different trends and, you know, tried to think about it in relation to what our testing capacity was at those moments and other factors that, you know, were influencing the sort of detection and the existing, you know, structural factors and experiences of racism and discrimination that may have been impacting populations at various points in time and impeding their, you know, participation and access to care. And so this has been a big part of what this working group has done, is to try to contextualize these patterns of race ethnic inequities and COVID-19 in the context of the neighborhoods that individuals live in, the historical, you know, legacy of structural racism and segregation, and, you know, try to, along as a complement to what health departments are doing on their own, many efforts on their own that are recognizing race as a public health crisis. You know, Milwaukee was one of the first places to put that, you know, make that official declaration. And so I think we view what we're doing as just a complement to the health department's work, and in any way that we can help them track and understand what's happening over time, we have been doing so. This is showing death rates by race ethnicity, you know, following a similar pattern. And now, you know, we've seen death rates sort of increase in non-Hispanic whites. So the overall rate per 100 cases is fairly similar among these populations now. And then this is showing just an example from the report that we have done for children. And so this is showing 18 and under, sort of now, you know, similar to every other age group, we've seen a surge in cases in children over the last few months in Milwaukee County, as well as in the city of Milwaukee. And then this is showing some demographic information, which is similar to what we report on all cases, but this is for children age 18 and under. So in the upper corner is showing according to whether the household income in the census tract that you live in. And so we see strong social patterning where those that are living in tracts that have the lowest or second lowest median household income, that the cumulative confirmed cases has been highest in individuals living in those tracts. We've seen a similar patterning and surge among Hispanic children in terms of the cumulative number of cases, and not much difference by gender. But now we are seeing a little bit of surge in those that are 12 to 14 over time. So, I think this ability to track this information and sort of augment what health departments are capable of doing has been a big role of this working group, and trying to just sort of be another resource to health departments during this time that they're experiencing workload and burden from COVID-19. So I will pass this off to Dr. Malco now, because she's going to talk about a working group that she has been a part of the UEOC.
So as Dr. Simonek was saying, the Unified Emergency Operations Center has been in progress. It's run by it's headed by Milwaukee County out of the County Executive's Office. So during the pandemic, obviously our county executive changed with the election. And in September, so it took 6 months, but in September, the UEOC stood up a community resilience response team. And the reason for that this was stood up is because the pandemic response had been primarily run by the city and town leads of the health departments, as well as the city leaders or town leaders, and then law enforcement and the fire, right? So this was like a standard kind of emergency response. But there really is very, very little to no opportunity in that kind of structure for really grassroots organizations that are serving the most vulnerable populations to have a voice in that decision making. So that's why this was stood up. It was an effort that was led by TJ Cobb, who is a graduate of our community behavioral health MPH program a few years back. And TJ really championed this within the TJ's employ in the Department of Health and Human Services, and really championed this work. And so this group has now been meeting since September. They explicitly define community resilience as the ability to respond and heal in a state of crisis, and the collective power to overcome racial inequities by ensuring social cohesion in the face of oppression and elevating protective factors across all social determinants of health. So it names oppression, and it focuses not on a deficit model, but on a resilience model that really builds on the strengths that come out of community. And it is heavily represented now, a lot of representation from the African American and Black community, and I think there's increasing efforts to have more representation from the Latinx community. Two priorities are basically to offer input on all of the other teams within the UEOC and really bring a strong equity perspective to those efforts, and then to identify opportunities to leverage the UEOC's position to actually address systemic inequities. And that would be related to what Dr. Simonek was saying about racism being declared a public health crisis in the county. And so this is one of the efforts to make sure that those systemic inequities are addressed as part of the pandemic response. And they just recently distributed a number of CARES dollars. Unfortunately, those dollars have to be spent by December 31st, but they distributed a lot of those to community-based grassroots organizations, both working on the north side and south side of Milwaukee, to meet the immediate needs of residents in those communities.
Okay.
Our students and alumni have been extremely active throughout, starting probably in the early summer. late spring. So dozens of our students are contact tracers and case managers throughout the county. All of these different locations. Our students and alumni are taking an active role in doing the contact tracing, which is absolutely essential, right, for breaking the chain of transmission in communities. So I just want to highlight some specific work. So these are go beyond contact tracing and case management. So these are actual specific kinds of projects that several of our students are working on. So Sarah Laurent, who's an epidemiology PhD student in the Zilber School, has been working on daily COVID maps for Milwaukee Health Department. She uses like geocoding kind of software. So it's basically spatial epidemiology. And so that's really important, been really important for understanding the relationship between place and COVID-19 distribution. Amia Peer has been working with the Oak Creek Health Department, and he has done a variety of weekly daily data reports for both Oak Creek, Cudahy, and South Milwaukee and St. Francis communities. And Caitlin DeGroot is with the state level Department of Health and Human Services with the Bureau of Communicable Disease. And she has been the COVID epidemiologist for the state. She's a graduate of our MPH epidemiology program.
So I'll just add a little bit that all of our MPH students between their first and second year usually engage in a 240 credit hour fieldwork placement where they work on a volunteer basis with a local health department, a community-based organization, nonprofit, to engage in public health practice work. And so many of our students upon, the pandemic beginning, either did end up working in placements that were related to COVID-19, or if their placement wasn't originally related to COVID-19, there became an element of COVID-19 related work to their experience just by the sheer nature of being in a pandemic. And so it's been, in many ways great that our students have gotten this real world experience. Of course, we wish that, we hope they don't need it again, but the likelihood is they will. So it's a unique aspect of our program that we place students in these areas. And it's kind of been very timely, I think, for many overtaxed public health departments and community-based groups at this time.
And I would also add that our epidemiology program is unique in the country in its emphasis on social justice. We have, we designed as requirements a course that students take generally in their first semester that I teach called Structures of Inequality and Population Health. So students learn the ways in which social hierarchies in society influence health. They learn how to examine the influence of policies and systems of oppression as driving health inequities. And so they're able to take that into their field experience and into their future work. And we require a social epidemiology class. We integrate an emphasis on health inequities throughout all of our curriculum. And so our students really focus on some kind of health equity as part of their field experience, or some kind of integrating some ideas and principles of social justice into their field experience, into their capstones in their final semester. And then they also take another class in the final semester called Epidemiology in Action for Equity, where they really learn principles of working authentically and ethically with a variety of different communities. So they really learn how to listen to community needs and respond to those needs in ways that really lift up communities. So it's unique in our program.
Yeah, and integral to it, yeah.
So it's really nice to see our students working throughout the county and throughout the state and bringing that perspective to all of their public health practice work.
And I will say, I welcome you to go to our Zilber website to see more examples of what students have been doing. We're in the epidemiology track and highlighted much of the epidemiology work here, but I know students across the other tracks as well have been involved in COVID-19 related projects. Okay. and some other examples.
Oh,
here
yeah. So
as
these are
well.
just some other examples.
Yeah.
We don't have to go through all of them, but so a variety, our students are working throughout the states. This is highlighting several other epidemiology students, also a biostatistics student.
Yeah. Okay. So the next part of what I'm going to talk about is around the work that I and others have done related to science communication around COVID-19. So, the pandemic has presented the sort of unprecedented amount of information around COVID-19 that, has been fast moving, new studies coming out, new guidance from CDC, from the World Health Organization. And I think early on, UW-Milwaukee asked me if I would be a media point of contact because they knew that, they would need faculty to respond to media requests. And I said yes. And so myself and others, even that weren't asked, have been fielding questions related to COVID-19. I found myself as an epidemiologist sort of getting asked by friends and family COVID-19 related questions as well, naturally, and being sort of that point of contact. And in early April, I joined on to a social media COVID-19 science communication campaign called Dear Pandemic. We have a mirror campaign called Querida Pandemia, which is our content in Spanish language. And so this is a social media campaign that was co-founded by Dr. Malia Jones at UW-Madison and Dr. Allison Buttenheim at University of Pennsylvania. We now consist of 14 PhD and MD trained female scientists. And on a daily basis, we curate the latest COVID-19 information and guidance across Facebook, Instagram, and Twitter. We have about over 51,000 followers on Facebook now, and about 7,000 on Instagram and maybe 6,000 on Twitter. We post 2 to 3 times a day. So we have a schedule and we all volunteer our time to basically answer follower questions. Started off with just doing this for sort of our friends and family, but has quickly expanded. And we found ourselves well aligned with something that the World Health Organization has made a call for scientists to engage in, which is called information management, because of this recognition that along with the pandemic, an infodemic was occurring, meaning an onslaught of both correct and incorrect and misinformation about COVID-19, that without sort of the assistance of scientists to manage that information for lay audiences was resulting in information overwhelm, people not knowing what information they could trust, not knowing what guidance to follow, and really serving to undermine the pandemic response. And I think that sentiment was shared by former, Milwaukee Health Department Commissioner Kowalik as well, in terms of that being a barrier and a challenge to their ability to engage in COVID-19 response. And so since April, we have been carrying out this campaign. I welcome any of you to go to our website or to these social media pages. You can submit questions to us. We have a live Facebook Q&A every Saturday with a subset of the 14 of us participating. And we, answer questions as we can and use those questions submitted to inform what we will post on in the following week. One challenge that we, faced is that this is a volunteer effort. While not all 14 of all the original 10 that started the group and now 14 of us are not white, we at first did not have any representation of a Black female scholar. And, it was a challenge, especially with the intersecting movement and protest after George Floyd's death, to sort of ask any of our female scholar friends to sort of join on to this volunteer effort when we couldn't pay them and we didn't, have anything much to offer. But as a group, a subset of people applied for funding from the Robert Wood Johnson Foundation to support a Black female scholar to join our team. And I'm happy to report that we received that funding and we have now had someone join our team. And we also received funding from the UW-Madison Holtz Center to support student to help us translate our post into Spanish language, which has allowed us to lift up the Querida Pandemia site. So, I think part of our mission is to provide science-based information in a nonpartisan way where people can come to us as a trusted source of information and cut through sort of the, you know, the mess of information that's out there. It's also to try to make information access more equitable, and to reach populations that maybe don't have the same access to information, or are experiencing targeted misinformation, you know, based on their, you know, race, ethnicity, or other characteristics. And so, you know, that's all a companion goal of this project. And then in addition to this effort that I've been part of is with the social media campaign, I've just across the board been involved in media engagement, as I mentioned. So a lot of local Milwaukee, Wisconsin media, as well as national and international media. You know, and I think what's been nice as an epidemiologist is to be able to use the skill set I have to help journalists to report accurately about the pandemic and to explain terms like what a positivity rate is and what, you know, metrics we might want to track and how to interpret data. Because in many cases, this is not something that reporters have ever had to report on. You know, we haven't had a pandemic in their lifetime that has necessitated translating science at this pace, and for, you know, such emergent and important needs of communicating what public health actions need to be taken and what measures people need to take to stop the spread of this infection and protect themselves and their community. So it's been a great opportunity to sort of liaison in that way in terms of science communication as well. And I don't know, Lorraine, if you want to add anything, because you have done a fair number of interviews as well.
No, I think we probably should try.
Okay, sorry, are we behind our schedule? Okay. Okay, so I'll turn it back over to Lorraine now to talk about some of the advocacy related work that faculty have done.
So one of the big areas that both Dr. Semenek and I have worked on since really the beginning of the pandemic is advocacy regarding COVID-19 and incarcerated populations in Wisconsin. As I'm sure most of you know, Wisconsin leads the nation in Black male incarceration rate. It's virtually double the rate nationally, you know, over 10 times the rate for incarceration of white men. So what that means is that, you know, Black men are disproportionately in prison or in jails in Wisconsin, and therefore, of course, vulnerable to COVID-19 in prison. And so COVID-19 has become a huge issue in prisons across the country. So there have been over 200,000 incarcerated people who have tested positive. That is probably a far underestimate because the testing in prisons has been very lackluster for the most part until there's an outbreak, and then there's testing increases. At least almost 1,600 incarcerated people have died since the beginning of the pandemic. It is important to point out that these are people who were not sentenced to death sentences. Okay, these are people who are serving sentences. Often, some of them are not even convicted of crimes, right? They're in prison, they're in jails and prisons, and they are sitting ducks for COVID, and they have absolutely no control over their circumstances. The COVID-19 death rate for a study that was published recently, that was through data through June, so it's probably much worse now, was that the death rate for US prison population was 3 times higher than the general population. So what we did is that we were actually contacted by some public defenders and asked us to write a public health declaration that was, you know, to protect incarcerated persons as well as correctional staff and Wisconsin communities from COVID-19. So Dr. Semenek and I drafted a detailed declaration, which we then revised in September. This declaration was also used in an ACLU lawsuit that sought the release of vulnerable people in prison amid the COVID-19 pandemic. That lawsuit was not successful. However, the declaration has also been used by public defenders seeking compassionate release of individual prisoners. We know of at least one prisoner who was released based on, at least in part, our declaration. the declaration has also helped to inform other advocacy work through news media and through, ACLU town halls and other work across the state. And it's been used by local community organizers who've sought release of people from Wisconsin jails. So it has been used. Of course, we have not had the success that we wanted to have when we first wrote the declaration in April. There had been no deaths in Wisconsin prisons. And what we heard, part of the reason that we revised the declaration in September is because the public defenders were telling us that the courts were basically saying, oh, well, no one's died in Wisconsin, so it's not really a problem here. So now we've had at least 14 deaths recorded. That is probably a far underestimate, because in order to be counted as a death, the medical examiner or coroner has to provide documentation that COVID-19 was an underlying cause of the death or a significant condition contributing to the death. And so if the coroner doesn't have that information, if the person wasn't properly tested, they didn't get an autopsy, then people could very well be dying, and COVID could be a contributing or underlying cause of death, and it would not be recorded. It has also been extremely hard to get data out of the Wisconsin DOC on deaths. I submitted a data request, yet to get any response from that. And other reporters and journalists have also attempted to get that data. They do now show the death data on the website, but that was just started being released within the past month or so. Next. So just to let you know that the main arguments that we put forth in this declaration, and we'd be happy to share it with you. I think any advocacy that can be done in this around this in terms of op-eds or other work that any of your members might do would be very much appreciated. Obviously, prisoners have inalienable human rights. I think that should go without saying, but we did have to say it. That pre-symptomatic and asymptomatic infection plays a major role in transmission of SARS-CoV-2, which is SARS-CoV-2, which is the virus that causes COVID. Because pre-symptomatic and asymptomatic infection plays a major role, it's very easy for staff to bring in infection into the prison without knowing it. And then once all you need is one, staff member bringing in, being asymptomatic, and then transmitting it to others. Wisconsin prisons are ripe for the introduction of the virus that causes COVID. There's overcrowding in Wisconsin prisons. The prison's conditions, there's multiple people to a cell or multiple people living in a pod together. So there's pretty much impossible to have adequate social distancing. They did finally start issuing masks, but it's highly unclear whether masks are really being worn universally. It would be very difficult for people to be wearing masks 24/7. Also, prisoners have disproportionately more underlying health conditions than even the general population. So they're more vulnerable to COVID if they get it. They're more vulnerable to hospitalization and death. So we have a very clearly laid out argument that decarceration is a public health imperative. That means that we should be decarcerating, we should be reducing the prison population in Wisconsin, which is already at the start of the epidemic was far too high. And so we made the argument based on public health that we should be decarcerating Wisconsin's population. The governor had, Governor Evers, when he ran for office, said he was going to reduce the population by half. And in spite of that, the pandemic being here, which was the perfect reason for reducing the population, excuse me, he has not taken the initiative and the leadership to do this work. Of course, it's politically difficult in Wisconsin to do this work, but that's why we need more and more pressure from residents like you to push our elected officials in the DOC to reduce the prison population, because without substantially reducing the prison population, there is no way for people to socially distance within the prison. And a 1 or 2 year sentence can become a death sentence. Another work that I've been involved in, we were recently funded by the Zilber Family Foundation Emergency Response Grants Program. So the Zilber School of Public Health received this grant. I'm part of a team that is of Black leaders and organizations within Milwaukee. This is a coordinated community-driven response to COVID-19 in Milwaukee's Black communities. It is, aside from me, a Black-led effort. Erica Sinclair, who's with Health Connections Inc., is part of the team, as well as Lorraine Lathan with Jump at the Sun Consulting, Quentin Cotton, and Pastor Walter Lanier, who some of you may know, who's with Progressive Baptist Church. Do the next slide. So this is a kind of an overview of our project and our effort. It was developed by Quentin Cotton. And basically just wanted to point out here that we have like 4 different efforts as part of our coordinated response. One is we have kind of 2 overarching objectives. And let me just back up and say that the reason that we're doing this is that despite the major county and citywide efforts to address the immediate, community needs in Milwaukee arising from the pandemic, there was insufficient infrastructure in the city and county for policy, funding, and resource allocation that centered the voices, perspectives, and deep knowledge of local Black grassroots organizations and community leaders. There is now the Community Resilience Response Team as part of the UEOC that is focused at the county level that I did mention that started up in September. We started seeking funding for this effort late in spring. So basically, we're going to extend the community outreach and impact of the Zilber School of Public Health to minimize the immediate economic, social, and health impacts of the pandemic on Black communities in Milwaukee by both utilizing a health promotion risk reduction strategy that will mobilize Black-led grassroots organizations to enhance the infrastructure within the Black community and strengthen the strategic networking and capacity of grassroots leaders and organizations to develop a coordinated, community change agenda that they can then push through policymakers at the city, county, and state levels. So this is a community-driven, bottom-up response to COVID, as opposed to the more top-down response that has been in place to date. As well, we're implementing with Erica Sinclair's Health Connections Inc., a testing, outreach, and education and linkages to services program in collaboration with Black churches and other faith organizations to provide accessible, free COVID-19 on-site testing in conjunction with outreach, education, free influenza vaccination, and referrals to primary care, mental health, and emergency needs services. And we're doing this in conjunction with faith-based emergency food distribution sites throughout Black neighborhoods in Milwaukee. I think we're running out of time, so I think I'll stop there on that. Oh. And then I'll just say that there are some other research efforts of our other faculty members. Dr. Linnea Lastidius has worked on 2 different efforts, one related to Wisconsin's nonprofit sector and seeing the impacts of COVID-19 on the need for immediate long-term support to ensure the ongoing provision of critical services in Wisconsin through the nonprofit sector. And she's also worked with Dr. Cho and Dr. Harley on a national food access and COVID research team, which is exploring the impact of COVID on food access, food security, and food systems.
Yeah, so again, you can go to the Zilber website where we're trying to keep up to date with the vast array of projects that faculty are involved in. And these are just a couple examples. And then some examples of publications that have been COVID-19 related, but there are others that are not listed here. So thank you for everyone's time and for tuning in. And with the time remaining, if we have any, we're glad to take any questions.
And there's a number of things in the chat.
Yeah, let's take a look at that first.
I'm not seeing the option to look at the chat right now.
So Frank Schultz asked that, he's heard the term viral load with regard to the coronavirus exposure. what is the significance of that? And can the immune system fight for a low viral load?
I think there is this concept of infectious dose. We don't know what the exact infectious dose for COVID-19 is. So how much of the virus you need to be exposed to become ill, or to get the infection upon exposure, and that likely varies across age and other characteristics depending on your sort of immune function and other susceptibilities. But yes, I mean, I think there's generally a concept around there being some level of infectious dose that's required for any one individual to get infected, but what exactly that is has not been determined and will vary across individuals.
So another question was, if I'm asymptomatic, isn't my temperature irrelevant? And I would say yes. So, this temperature checks business that people do in various places is really not a very effective screener for COVID. I think it's mostly at this point, Amanda, you can chime in. I think it's mostly to make people feel comfortable. I mean, maybe it's an additional recognition or additional affirmation that you shouldn't go anywhere if you are symptomatic. But early symptoms of cough and can come without any fever at all. So most people I think if they had a fever. So it's
I think the important thing to know is that starting about 2 days before you do develop symptoms, among those who develop them, you can transmit this infection to other people. And so the best things we can do are to social distance and wear a mask and pretty much assume I may have been exposed and not realize it yet, and I don't want to transmit it to other people. So wearing a mask and keeping distance from people, staying out of poorly ventilated indoor spaces, regardless of whether you know you have the infection or not, is our best strategy. And like Lorraine said, taking a temperature will certainly identify those that walk in the door with a temperature, but it will not pick up very many people who don't have symptoms of COVID yet that actually are capable of spreading the infection. And, and sometimes the people refer to this as sort of hygiene theater, like this idea that we're doing things, but their effectiveness is not, far less than I think the strategies of distancing and wearing masks.
Yeah, so related to that, Ann Batiza asked, I often meet trail walkers not wearing a mask. How risky is that for them and for me?
I think passing someone quickly on a trail in the outdoors is fairly low risk. I can't tell you everything is 100% risk-free. It's better. I wear a mask when I go out, walking the dogs, just in case I do pass somebody. I want to make people around me feel comfortable that I have a mask on and I'm wearing that to protect them. I think if you're walking on a trail and you have space to move to the side and give yourself a little more distance between people, that's great if they're, not wearing a mask. But generally, compared to being in an indoor setting without people wearing masks, being outdoors is safer.
Yes, so Bruce Wiggins asked, regarding communication, what is your experience about the limits of social media and computer like virtual communication? Says he imagines many people needing information do not use these media as much as others. Yeah,
so there's a certain demographic of people who tend to be on Facebook, Instagram, or Twitter, right? And so not everyone will be accessing their information along those platforms. And there are also platforms that are ripe for spreading and sharing misinformation, right? But I think, especially what we hope to do with our campaign is we have a real nice, strong community of followers who are there because they want to get information that's factually correct that they can then share and spread and propagate. And sometimes some of our posts, according to the Facebook metrics, reach 100,000 people. So, we have some indication that people are sharing them for the intention based on their comments that they include with the shared post. They're sharing it to combat misinformation, and that they, in some cases, are very far reaching. We haven't been, necessarily able to quantify how much of a dent that makes and compared to the misinformation that gets spread, and I think what's nice now is we have a website. So some people maybe aren't on those social media platforms, but would go to a website, and you can search all of our past posts by topic on keyword. And you can also find a particular post and send that to a relative via email, or even print it off and give it to them if this is something that, they're not using social media very much. Lorraine, I don't know if you have some other thoughts on that or insights.
Well, I mean, the digital divide is a big
Yeah.
issue. Lorraine Lathan, who's part of the team with the grant that I was talking about, has been doing a lot of work in Milwaukee on the Northside communities, really trying to bridge that digital divide. It is a big issue.
Mm-hmm. I think, that's been part of my motivation too, to do interviews for Wisconsin Public Radio and other media sources that are not internet based, but maybe have different demographics that access them and can get information that way.
This is the third Lorraine interrupting. Could you move your screen on, because then we'll see a larger image of you.
Oh, they want you to close the presentation.
Can you close the presentation?
Oh, sure.
Sorry, didn't use the right words.
Okay.
There, great. And
okay.
are there questions? Are people looking to ask questions who haven't put them on chat?
Okay,
They could raise their hand.
sure. I don't know if
There is another question. There
Okay.
were questions in the chat, but.
Oh, okay.
Well, Frank said, if I'm interpreting the data correctly, there seems to be reluctance in some ethnic groups to seek medical assistance to address illnesses. And is this because of financial considerations? And then someone else, Bruce, replied that it can also be fear of authorities in immigrant communities and fear or suspicion of medical practice in minority communities because of past injustice. I don't know if the data is showing that some people are not seeking medical assistance. I mean, there are higher hospitalization rates among African Americans or Blacks. It's not clear that that's because people are not seeking care or whether there's barriers to care. I mean, we do know that there is higher uninsurance rate. We do have federally qualified health centers and other clinics that will take people without insurance. So we'll offer care, but I mean, there are some people who are where they might not be getting to the hospital fast enough. And so one of the things with COVID is that it's really important to be able to monitor like your oxygen levels. And often the oxygen levels will drop and people won't know that they've dropped, right? And so then if you're not in the hospital when they first start dropping, then it can lead to more, the care can't, if you wait till later, then it's harder to treat COVID and more likely that you might end up on a ventilator. So
and I think some of the things also we're aware of as structural factors that influence your likelihood of exposure to infection fall along socioeconomic factors in terms of if you're in a position that you have to work in person, for instance, and you're an essential worker or working in a grocery store or working in public transportation or other areas that you don't have the choice to work from home, that is going to fall along socioeconomic gradients and be a barrier and be a reason that you might be exposed over someone else, right? And that part of what we looked at in the social determinants report was living in areas a high proportion of essential workers, and found that early on in the pandemic, that was that the rates of infection were much higher if you lived in an area where a high proportion are essential workers. So there's I think a few different factors working together that have contributed to the social inequities in COVID-19 that we've observed in Milwaukee. Was there another question in the chat, Lorraine, that you saw?
So I have read due to people not following proper social distancing in public and with so many contacts that contact tracers are so overwhelmed that many more are needed to make it effective. And that is definitely true. The Milwaukee Health Department in the last month has had to go to partially, volunteering, basically asking people to do their own contact tracing. So this is in many health departments across the state are in a crisis mode with contact tracing. Contact tracing, when we have this high of levels of COVID, are not effective.
Yeah.
We don't have enough contact tracers to deal with this level of.
Yeah. And so the objective of contact tracing is that when someone tests positive, they're interviewed to determine who they might have been in contact with in the 2 days before symptom onset, or starting the 2 days before their positive test. And so if individuals who test positive can't be contacted quickly to ascertain that information, then those individuals who they may have exposed during that period also don't get followed up with. And so in many cases, there are some electronic ways that people can anonymously notify the people that they've been in touch with, that they, have been exposed to a positive case of COVID. The best thing that everyone can do, though, is to keep your social circle small and consistent, so that, the likelihood that you're exposed is lower, and that if you do happen to be exposed, you weren't likely to pass it along to other people, right? So I was asked back in April, should we be keeping track of our own contacts? And I said, yeah, that's great, but keep that list very short.
Okay, anybody else who wants to ask questions now needs to unmute themselves.
Yes. I have a question. Can you say something about the infection rate? I don't know if I saw that in your charts. It seemed like that's really important. Your charts that were showing the hospitalizations and illnesses seemed to peak in November. Seemed like a lot has happened since then. So is there any difference that you see in the infection rate between now and say a couple of weeks ago?
Yeah, so those reports contain data through November 24th. And so you could check back to those links, and you can find updated reports as that data comes in. What we experience is there's usually a bit of a data lag. And so we have sort of preliminary data. That's the most recent, week or so. And that data doesn't get included in reports because we're still waiting for, any lags in reporting to come in. But to your question, yes, we are waiting to see, it looked like there was a bit of a downturn in cases, which is great, because maybe that means that people were, on their own accord, making more effort to wear masks and to social distance and to sort of cut off those chains of transmission. But we are waiting to observe kind of what potential, holiday gatherings, what cases were generated during those times. And that will take a bit to be detected. And then, of course, we know there'll be a lag between when someone becomes infected and when they have severe enough symptoms to require hospitalization, and then, unfortunately, a further lag to deaths, right? So we kind of know we need to wait a few weeks after a period where we suspect increased exposures to have happened to observe the effects.
Yeah, and I would also say that, so what the state tracks, what the county, city tracks, if you look at the testing data on each, you can Google, Wisconsin COVID dashboard, Milwaukee County COVID dashboard, City of Milwaukee COVID dashboard. It's called a dashboard. And if you Google any of those, you'll get the latest data. And if you look at the testing data will indicate percent positivity. So that's going to be, of all the people who are being tested, well, some of them it's based on the test and some of it's based on the number of people being percent positivity based on people. But regardless, it's basically, of those being tested, whether they're positive for COVID or for SARS-CoV-2, which is the virus that causes COVID. So that's percent positivity. The rates that Dr. Simonek presented are basically those rates of people testing positive divided by the overall population. So that would be more like like an infection rate. That would be that. But all of it's dependent on people getting tested.
Yeah.
So the rates have gone down in the last week and maybe 10 days, but also testing has gone way down. Mm-hmm. So many people were getting, there was there was a big testing surge, prior to Thanksgiving. Maybe some people were thinking of, well, if I test negative, then I can go visit my family, which actually wasn't a correct assumption. But so many people were getting tested before Thanksgiving. And then because of the holiday, you know, the testing sites weren't open as often. And then now this week after, we haven't gone back to the levels of testing that we had prior to Thanksgiving. So again, if people aren't getting tested, then you're not identifying many of the cases, particularly the asymptomatic cases. And you have to wait for them to become hospitalized before you really see it in the numbers.
Yeah, or the second transmission to occur from somebody who wouldn't get severe disease to other people in the community who will.
Just a general question. It seems like there's less data reported on the weekends. I'm wondering why that is, and does those numbers then fall into the weekdays somehow?
Yeah, so I always tell people to look at the 7-day averages, and also on Mondays, those reporting numbers are also sort of low. And the reason for that is public health people are not necessarily working over the weekend or getting paid to work. Labs are not necessarily operating. So there are sort of those weekend dips. If you look at like a trend over a month, you'll see a consistent dip on Monday, and so looking at sort of a longer term pattern can smooth out some of those anomalies in data collection and reporting. Yeah.
Thank you.
Just a quick question. Does your website have a newsletter or a periodic update via email?
Yeah, I just saw that, and that's a great idea. So that's not something we've done, but I will bring that to our Dear Pandemic team, so in addition to coming to dearpandemic.org and kind of getting access to the questions we've asked, maybe we could set it up so that people receive a regular update by email with the posts that we've done that week. So that's a great idea.
Not being a social media user, I would really appreciate that.
As long as you use email, then yeah, that would work. Yeah.
Thanks.
I have a question now related to herd immunity. Some places have indicated that 8 people actually have had COVID compared to the number who've tested positive. And if you start multiplying those numbers, you can end up with close to 50% of the people in Milwaukee having already had the disease. Can you say anything more about that?
Yeah, I think, so the estimates that are thought to be needed for herd immunity for SARS-CoV-2 are probably close to 70% of the population. And what herd immunity means is that enough people in the population have been infected that any one person who has COVID-19 is sort of unlikely to even encounter a susceptible individual at a rate high enough to continue spreading that infection, right? And so the herd being infected protects those, few that are not infected anymore. And so we do certainly think there are undiagnosed cases of COVID-19, people who are asymptomatic and who just never know they were infected. What portion of people that is, I think estimates vary. I've not heard an estimate that 50% are thought to be previously infected in Milwaukee. The way that we can assess that is to do population level serology testing, where we look for the presence of antibodies against SARS-CoV-2. And as I understand it, we have not done much population-based testing in the state of Wisconsin or Milwaukee. Lorraine, if you have insights into that. But I'm not aware of any data that has quantified sort of how many people we think actually have the infection. Even in New York and places that were hard hit early in the pandemic, I think those estimates from serology-based studies were about 20%. The highest I've seen of, rates of infection based on sort of testing for presence of antibodies was in Brazil, where we know that infection spread very rapidly through impoverished areas. So I guess my overall point would be, I don't think we are reaching herd immunity. And more importantly, we don't want to try to do that through natural infection. And the fact that we have vaccines on the horizon is all the more reason to buckle down and sort of engage in the public health measures we know work, because we want people to survive to get the vaccine and to reach herd immunity through vaccination. That is going to be the way that the fewest people die from COVID-19 and suffer short and long-term complications from COVID-19. We don't want to allow the infection to just rip through the population. It's not really a strategy. It's more of a giving up and allowing it to just, infect at free will. So that's what I would say about herd immunity. If you have something to add, Lorraine, please do.
Well, I would just add that the data indicate that we've definitely not reached herd immunity because the infection, just because of the infections are still at a really high rate.
Yeah.
Right. So if we had reached herd immunity, we wouldn't be having.
It would have slowed down.
Yeah.
I have a question. Is there a place in Milwaukee where one can get the antibody test? And the other is, if you could say something about what has happened in Sweden. They've been kind of going a different route, and they seem to be successful, but what's the latest on that?
So in terms of getting antibody tested at the individual level, it's a more useful tool to test an entire population because there'll be sort of issues of precision, and we can get basically a rough estimate at the population level of how many people have likely been exposed. But at an individual level, there's the risk of having sort of a false positive result, it appearing that you have antibodies when you don't, or some of these antibody tests may pick up antibodies from similar coronaviruses and give you a false positive result. So I wouldn't actually recommend an individual rely on an antibody test, unfortunately. Also, we're still learning about what the long-term immunity is from natural infection. So I think, one of the concerns is that if someone gets an antibody test, even if they were infected, we don't understand well enough how long natural infection immunity would last based off of antibody levels alone. There may be other immune markers that are more informative of that immune response that you triggered and are able to then respond to the infection in future. So that's what I would say about antibody tests. There certainly are places you can go and you can order from companies, but it wouldn't be my recommendation to rely on that. In terms of commentary on the situation in Sweden, I think actually we posted on this on Dear Pandemic, and I would probably refer you to some of those posts because some of the experts that I work with have made commentary on what the strategy was there. I think there's a lot of misunderstanding about exactly what their strategy was. And I think now, they are suffering from high rates of infection at this point in the pandemic. So it wasn't necessarily a success, but I don't want to speak specifically on it. I would direct you to those resources on the Dear Pandemic page.
Okay, maybe we can have one more question and then wrap this up. Okay, I guess if there are no more questions, I'm going to now.
Oh, I'm sorry. I was muted. I'm sorry.
Okay.
Some people point to survival rates as a reason to not be as concerned about COVID, but survival can be kind of a relative term in that there can be long-term health implications from an infection. Are we gathering that data and sharing it? Because I think it might change some people's minds about the severity of this disease.
Yeah, I think it's a really good point. So I would say, estimates, first off, range from the fact from COVID having a 2 to 10 times higher rate of death than in seasonal influenza, based on that data we have available on estimated case fatality rates. So it is, thought to be more deadly than seasonal influenza. But even if you get this infection and you don't die, there are a set of people who are called COVID long haulers that sort of are having prolonged symptoms from COVID-19. And, there's potential for other tissue and body organ damage from this virus that we are still learning about. So I think we should not think of mortality as the only adverse outcome of this infection. Yeah, but you're right to point out that there could be other sort of long-term problems that result from getting this infection that we're learning about and still studying and collecting data on people who are having prolonged symptoms and problems.
You know, the other piece I would just say is our hospitals have never been overrun like this ever, I think, in history.
No influenza season, no, yeah.
Right. So I think that unfortunately, you know, we're just being able to collect data, and it's going to be a while before we see the impacts, but the data that has looked at excess deaths has shown that there, you know, like in New York City, there were a variety of excess deaths from other causes during the pandemic because people either weren't going into the hospital on their own or couldn't get access to hospital treatment that they need for other kinds of conditions, like, you know, heart attacks or strokes or, you know, any other kind of, you know, severe trauma, any other kinds of reasons why people go to the hospital and why people are in the ICU on a, you know, everyday basis. When the hospital fills up, it's impacting all
other health
it's
outcomes,
impacting hospital care across the spectrum, and then it's also impacting people's access to what some people are, you know, what's called elective surgery, but elective surgery can actually be totally medically necessary surgery. So elective doesn't mean elective like, oh, I'm going to have plastic surgery. Elective means, oh, I need to have, you know, the lump in my breast removed because I've been diagnosed with breast cancer, but it's not, I don't have to have it as an emergency done right this very second. But I definitely need it done quickly, right? So all of those kinds of, when the hospital's overrun, all of those kinds of other care for cancer, for heart disease, for all other kinds of chronic conditions are impacted.
And nursing and, you know, physician staffing becomes challenging, or people get reallocated to units they don't normally work on. So it's not just the physical beds that are available, but the staffing issues as well. And I would just build on what Dr. Malko said, that it's estimated right now, if we just think about comparing the number of deaths that happened in 2019 to those that have happened this year, that we are in the US, there has been about 300,000 excess deaths above and beyond what we would expect based on last year. And so some of those are most definitely COVID-19 deaths, and some of them are the deaths that occur because of the burden of COVID-19 on hospitals. You know, and so if we just ignore, you know, any issues of trying to classify people as a COVID-19 death, we know we've observed that many more deaths this year.
Okay, I think this is a good time to stop. I'm going to stop the live stream right now. So thank you so much for this wonderful presentation.